Hello, my name's Dr. Fionn Davis and I'm a consultant in emergency medicine. What we're going to talk about today is how to identify a sick child, and that means a really sick child, not just a child with minor illness. And I'm not also going to talk about chronically sick children with serious diagnoses such as cystic fibrosis and that sort of thing. So every year in the UK, about 5 million children are brought to urgent and emergency care, that's walk-in centres, emergency departments, and then millions more are taken to the GP with an acute illness. And in all of this, how can we work out which are the sick ones that need admission to hospital, and of those who are admitted, who's going to actually deteriorate and even worse, die? And that's a little bit like a needle in the haystack. 25 years ago, the world was a different place. Parents would come much later in the presentation of disease, and it was actually quite a lot more obvious that a child was very sick. Whereas now we have these millions of children in a sort of grey zone, and we're trying to work out which are the really sick children. And in the UK, of course, not very many children are very sick. So it's a little bit like spotting the needle in the haystack. So what I'm going to talk about in the next few minutes is how to tease out at the end of your consultation which of those children are potentially going to deteriorate and which ones can go home quite safely. So, as any clinician, you're going to take a history and you're going to do an examination. And what we're going to do is put another little step before history, which I'm going to call risk stratification, and I'll explain that. And we're going to talk a little bit about the history and some things that you need to tease out from the history. And also, in terms of examination, what do we mean by examination? And we're going to talk about the power of observation, observing the child, and the observations, in other words, the vital signs. So what do I mean by risk stratification? Well, sometimes it helps to just stop and think, is this child actually at an increased risk of dying? And there are certain things that do make children at an increased risk of dying. Those are any child who hasn't got a clean bill of health. Most children are healthy children, but if a child's been born prematurely, has some kind of syndrome, or is diabetic, all of those things do actually increase the risk of that child getting into trouble. And it's worth just stepping back and remembering that. And age really matters. So when you first start paediatrics, perhaps all children scare you a little bit and you're a little bit underconfident, but actually most children over the age of 2 have quite a good immune system. Those children under 2 should concern us more, and particularly children under 6 months old and particularly children under 6 weeks old. So if you're a little bit on the fence and you're not sure whether to admit a child or not, have a look at the age, because that should help you make your decision. So that's our risk stratification. Now we're going to go on and take a normal history and examine the child. And in the history, you'll find that a lot of things are very common in paediatrics. In fact, when I first started paediatrics, I couldn't understand how so many children would come with either a bit of a temperature or vomit or not quite right. And within 24 hours, the paediatricians would have made diagnoses such as brain tumours and meningitis, and it seemed to me quite difficult to get to that stage from the starting point, which was quite vague. Imagine how many children get an upper respiratory tract infection every year. Children under the age of 1 may have 6 or 7 upper respiratory tract infections in that first year of life. So be a little bit careful about that history, because it might not be the diagnosis this time. The other thing you might hear is, he's not keeping anything down. We need to clarify that. Is that 1 vomit? Is that 20 vomits? Is it only for food, or is it also for drinks? You'll also hear the word diarrhoea. Is that 1 loose stool? Or is that 20 explosive stools in the last 24 hours? So again, we need to clarify that. You'll also hear phrases like, he's not himself. A lot of children, when they're feeling unwell, will clearly not be themselves, but in between episodes, most children like to play. So do we mean that this child really hasn't played or shown any interest in anything over 24 hours? Or have they had their up and down periods? And that's the most common way of presenting, and parents will be apologetic and say, oh, I'm sorry, he didn't look like this an hour ago, or he's much better since we gave him some paracetamol. And that up and down pattern is actually quite reassuring. So let's come on to examination. You're going to do your normal examination and you're going to look at this child. And if the child's 12 years old and has a sore throat and you look and you see tonsillitis, then you don't have to do a full examination. But actually in emergency care, an awful lot of our patients are in the younger age group, and there a full examination really does matter. So a proper top to toe, front and back, ears, throat, etc. really does matter. But I'd like you to just stop and think a little bit about observation and observations. So observing the child's behaviour, as we talked about when we're taking a history about behaviour, will also make quite a difference. And the child that's running around eating crisps is generally going to be a well child. But in those drowsy children, which is quite common when a child is ill, you need to work out, are they really drowsy, or can they be woken up and played with? And that's really important, not to just let a child sleep. Are they actually irritable? So a lot of children cry when they're being examined, but are they distractible, are they consolable, or are they truly irritable? Because true drowsiness and true irritability matter and should matter, but we need to make sure that it's not just that the child needs a bit of comforting. And then of course observations means vital signs. You can actually do a full set of observations as well as a full top to toe, front to back examination in under 3 minutes. So it is easy to do and it's worth it. For observations, we're talking about the vital signs. So we mean heart rate, respiratory rate and pulse oximetry for any child that may have difficulty in breathing. These are important because it is quite hard to spot the needle in the haystack for diseases such as meningitis or other severe sepsis. And it's the heart rate that might jump out at you. If you know your normal ranges for that age of child, and if not, use one of the Pews scores, and there's a high heart rate, that might be a sign of sepsis. In the same way that pneumonia is quite difficult to diagnose in children, and perhaps the only sign for that might be a high respiratory rate. So again, you need to know your normal values, and you need to think, is this child compensating? Is it abnormal but it's coping? Or is it actually decompensating and at severe risk of deterioration? So we've talked about risk stratification, we've talked a bit about the history, and we've talked about examination. We'll just stop for a moment to talk about fever because it's such a common presenting symptom, and there are two very common questions that people ask. First is, does the actual size of the temperature matter? Because it matters a lot to parents and they'll often come because he's got such a high temperature. And the second thing is, what about antipyretics? What is the role of an antipyretic? So does the actual temperature matter? Well, the degree of fever does correlate to the risk of serious bacterial infection, but not very well. There isn't a great correlation and individual variation is quite wide. So some children throw a fever at the slightest thing and other children don't. So for that child in front of you, really the degree of fever doesn't make very much difference. One point worth making is about babies under the age of 4 weeks. For babies at this age, if they have sepsis, they may not have a fever. In fact, they may be hypothermic, so anything under 37 degrees centigrade should be taken quite seriously. And what about antipyretics, ibuprofen, paracetamol? Well, these are very, very useful drugs. They will reduce a fever, but they will do that because they're a drug that reduces fever. What you mustn't do is take that to mean that the source of the fever is less serious, because the drug will reduce the fever. But in doing so, it'll make the child feel better. So when we're trying to see what the child's really like underneath, it's important to see what the child is like with the fever removed, and that's when we can go back to assessing behaviour as we talked about earlier. It also removes the effect of fever on those vital signs. So when we're looking at our observations, it's very good to remove the fever and now have another look at your heart rate and your respiratory rate and see if indeed they are raised. What you mustn't do is assume that if we remove the fever and the fever comes down, because of the pharmacological effect of these drugs, that the underlying cause is less serious. So that's a little bit about fever, but you might still be feeling a bit underconfident with children, and I think that that's natural for all of us. There are some useful resources out there to help you, and I'm going to point you in the direction of two. One of them is something called the POPS score, which is the Paediatric Observation and Priority Score. This is a Pews type of score, and there are several around, but this one has been designed for use in the emergency department or other settings like urgent care settings. The advantage of the POPS score is it not only identifies the very sick end of the spectrum, but it also can help you confidently discharge children who are well with the low POPS score. And here's a web link to information and resources on the POPS score. The other resource I'd like to highlight is a website called spottingthesickchild.com. This is a website that was first commissioned by the Department of Health and has endorsement from most of the major Royal Colleges. It has many hours of footage of real-life patients, which perhaps in a lifetime's practice you may not see so many sick children. So I would highly recommend it. It's available for free. You do need to request a password, but that will come straight back to you, and it has an awful lot of supportive material. One of the advantages is that it is real-life footage, and you can see on this still of a child with recession that actually, if you haven't got an experienced eye, you might not understand what recession means or whether it's mild, moderate or severe, but the beauty of video is that it teaches you on real-life cases. So in summary, what are the top tips for helping us get it right? Which children need to be in hospital and which children don't? So the first step is to stop and think before you start. What's the age of this child? And do they normally have a clean bill of health, or have they got underlying problems? Then in the history, it's all about clarification, making sure we get to the bottom of what the parents are trying to tell us. In examination, we're going to do top to toe, front to back, and we're going to remember observation, what is the child's behaviour like, and observations, what are the vital signs. So that's all from me. I hope you found this information useful. Thank you very much.